I think one of the potential benefits as well with liquid biopsies is they better capture the heterogeneity of the lesions, because if you do a liver biopsy or a lymph node biopsy, for example, with ESR1, you may or may not pick up on that mutation, but you're getting all of that tumor DNA in the bloodstream where you are having a better chance of perhaps picking that up. And just to confirm, at every progression, you both are testing on liquid. So even if a patient didn't have an ESR1 mutation at progression on a CDK inhibitor and you put them on a different treatment, again, when they progress again, you're checking again.
At every progression where the next line of therapy is still possibly endocrine-based, but if this is a very fast progressor, somebody who is having primary endocrine resistance, and we're moving on with chemotherapy or ADC, I think it makes less of an impact on our clinical decision. Generally, yes.
Same here. When I'm still considering endocrine therapy, I will test at every progression.
And I think our guidelines are consistent with that approach. I know we're going to be getting into a discussion regarding treatment sequencing and options, but you showed us some data on CDK4/6 inhibitor use beyond progression, and as you pointed out, we had a negative trial with the PACE study, and then we had the MAINTAIN trial, and then the post-MONARCH trial, which did show us a benefit of CDK4/6 inhibitor beyond progression. And you also showed us some data that strategy may be effective even in patients with ESR1 mutations or PIK3CA mutations. But to be fair, we have other drugs to consider in that situation. How are you selecting out patients that may be appropriate for CDK inhibitor beyond progression? Are you only considering it in those who have no other option based on their mutation status?
Yeah, for me, I think the absolute benefit for both the CDK4/6 inhibitor, like the classic at least CDK4/6 inhibitor switch strategies, MAINTAIN and post-MONARCH, was just a very small clinical benefit, and so I would only consider it for patients where I didn't have a biomarker-driven other targeted therapy option.
What are you doing, and what's your success been in clinical practice?
It's really quite variable, but I would say that with some patients, when I, for example, applied the post-MONARCH strategy, I have a patient that's been on that for more than a year, surprisingly. And I dose reduced so much. Right now she's on 50 BID, but still good disease control. I find that to be quite relevant in patients that have sort of a very mild disease progression. And sometimes they do have a mutation like a PIK3CA or P10 or AKT, but they're really bad candidates for that pathway because of metabolic issues. Yes, I think it does sometimes clinically do a lot better than what we've seen on the trial.
Right, and it just makes the point also to individualize these decisions, right? It's not, for each individual, you may choose a different option. You know, the last slide you ended with was the promise of combinations, and in our pre-survey, when we had the case where the patient had the ESR1 mutation, it was interesting to note the majority that would have used the SERD used it in combination with abema, basically the imlunestrant-abema combination, as opposed to single-agent elacestrant. So as we move towards combination strategies, is more always better? Are there any patients that maybe are appropriate for endocrine monotherapy? I mean, I think we all have these patients in our clinic, right, who have really long periods of control on a CDK4/6 inhibitor. I know I had a patient who was sort of put on the chemo train, so to speak, and had not been given an adequate course of endocrine therapy. I found an ESR1 mutation. She was on elacestrant for 12, 14 months, single agent. So we know the toxicities of combination strategies. So how in clinic should we make these decisions about who needs a combo versus monotherapy?
I think it's an important discussion, Reshma. I think in the interest of time, glossed over toxicities, but anytime you add a targeted agent, you're generally adding the sort of toxicities that are associated with that. Patients get comfortable on whatever their first-line therapy is, often AI plus CDK4/6 inhibitor, and so a change in therapy, I find I'm often met with a lot of resistance, even when it's just to oral SERD monotherapy, which is thankfully, generally very well tolerated. So I think that has to be part of the discussion. I think, initially may not have had, the best clinical efficacy with every patient that I put on, let's say, elacestrant monotherapy, but that was because it got approved and I was trying to put patients on their fourth-line endocrine therapy on, an oral SERD monotherapy. But, seeing that subgroup analysis of patients who had, long disease control on their first-line therapy, I think the conversation has become different. Certainly when patients are motivated to have that sort of deepest response, longest progression-free survival as possible, I think targeted therapy often makes sense, but we're still finding out.
Yeah, I agree. I think the philosophy for so many years has been we are layering one drug on top of the other to get the best response. And so we always think that this is the best thing to do, but not really. I think when elacestrant came to the clinic, it was coming at a time where a lot of our patients that were treated were heavily pretreated in clinic. So many of my patients saw 4 or 5 lines of therapy before they got onto elacestrant. And to my surprise, I have more than one patient, and they are sort of bone-only or bone-dominant disease, and those are long responders. Some of them are more than 12 or 16 months. I haven't had anybody with liver mets. Even though when I look at the trial, I do see that the Emerald trial did include a very heavily pretreated population and a high-risk population, a population that we've seen that more than 70% had visceral mets. Mm-hmm. And when they break down the visceral mets that we've seen, we'll see that 50+% were liver mets, which is usually the worst type of visceral mets. Yet the level of benefit was maintained and the PFS was maintained in those population. So I agree. I don't think combination therapy is for everyone. I think there's a lot of exciting ongoing translational work that is looking at the intrinsic subtype and RNA platforms to further identify who are the ER responders that will respond best to the next-gen oral SERDs and who need combination therapies. So,
and I think you bring up a very important point about our temptation to do cross-trial comparisons with regards to efficacy, but it's important to note that the patient characteristics on these trials is very different. Like, you brought up the patients in Emerald who were including endocrine-resistant patients, those who had prior chemo. And so again, as we look at the data in clinic, understanding how to apply it, understanding who those patients were is a really important aspect. And I think that also brings up, the discussion on real-world data. I think real-world data helps us sort of bridge that gap between trial populations and everyday clinical practice, and it adds a level of granularity for us to help with treatment sequencing. How does real-world data fit in? You showed us some of the elacestrant real-world data. Is that in line with your clinical practice?
I thought the real-world data was really encouraging and inspired me to, not be afraid to think about oral SERD monotherapy. You saw that even patients with co-mutations, so PI3 kinase and ESR1, had 5 and 6 month median time to next treatment, 8.8 months in just all patients in the real world groups, which I think is a very reasonable median PFS for a well-tolerated endocrine therapy. So I think that was very important pieces of data that were each published last year.
One question that's come in through the audience, and I think we're all grappling with, because now we also do have imlunestrant approved and available. These drugs, imlunestrant and elacestrant, mechanistically, they're slightly different. And one person in the audience asked, for ESR1 mutations, how do you decide between elacestrant versus imlunestrant? How do you think about these two SERDs?
That's a really good question with no easy, straightforward answer, but one of them is an agonist-antagonist elacestrant, and one of them is a pure antagonist, imlunestrant. I go back to the way that the trial defined its patients. So in the Emerald trial, this is a heavily pretreated population. Everyone has seen prior CDK, which mirrors our experience in real life. A quarter of our patients on the Emerald trial did see chemotherapy. A quarter of the patients were previously treated with fulvestrant. And also, there is a decent amount of patients that had visceral involvement. And so one important pearl that I keep in mind when I'm deciding whether I should use elacestrant or not in clinic is how long of a duration of benefit did my patient have on prior CDK in first line. And if it's more than 12 months, then I am more encouraged to prescribe elacestrant. If it is less than that, then it is less likely that I would